Members of the committee, members of the public, legislative staff, let's go ahead and call the meeting to order. We do have some brief housekeeping issues that we need to address before the formal meeting. First and foremost, if I start coughing, bear with me. I got a cold this afternoon, but I'll get through it. First of all, the language of the statute is unclear as to whether or not non-legislative members of the committee are entitled to a per diem. It's the position and the opinion of the chair, and I want to make it clear that it is the legislative intent, Ms. Liz, that non-legislative members are entitled to a travel per diem. As some of you may know, I do not have a legislative committee assistant whenever we're out of session. So Senator Michelle's committee assistant, Ms. Deborah Stamps, has had the responsibility of preparing and typing up all of the agendas and making the phone calls. So we, on behalf of the committee, Ms. Deborah, we thank you very much for the job you have done. Thank you. A reminder for the speakers and the members of the committee, please speak into the microphone. That's very important. We listened to the meeting from the last one, and we were not able to pick up several conversations and the speeches that were made by several of the members because they were not speaking directly into the microphone. One last thing, we have decided the next meeting will be on October the 23rd. If anybody has a conflict with that, please let us know. That is subject to change if we have too many people with the conflict, but you gotta let me and Senator Michelle know ASAP. And I think for the housekeeping items, I think that's about it. Let's go ahead and go to the agenda. And we do have a quorum. As we like to say in the House, ladies and gentlemen, we have a walking quorum. And that reminds me, Carlo, do we have anybody that's attending by Zoom? How many? Okay, and who are they? Is who? Okay. Well, Amy and Adrian, welcome. Thank you for attending by Zoom. And please make sure you get our attention if you have any questions or comments that you want to make. Okay, Senator Michelle, members of the committee, the first speaker that we have is Ms. Christy Davis, and she will be speaking on behalf of the Mississippi Obesity Society, and I assume the effectiveness concerning some of the pharmaceuticals associated with obesity. Ms. Christie, the floor is yours.
Thank you. And I want to say that I'm very appreciative of this opportunity to come and be able to speak with y'all. I'm hoping that I'll be able to give you a little bit more insight into obesity as a chronic disease. So a little bit about me. I'm co-chair of the Mississippi Obesity Society. This is a nonprofit that I started this year with Dr. Tim Quinn, he's a family physician, and Gabe Ibarra, he's a physician assistant. This is how serious we feel about this. This is all three provider types agreeing on something. We've got to do something about obesity in Mississippi. I'm also a family nurse practitioner in a local endocrine clinic. I have extra training in obesity management, endocrinology, and diabetes care. I have a few disclosures down there. What that means is I've never turned down an opportunity to speak about obesity. There we go. So I want to start with talking about obesity as a multifactorial chronic disease that leads to many other complicated diseases. I think the fact that this is a chronic disease really gets lost in the numbers when we're looking at other things. In 2013, the American Medical Association recognized obesity as a chronic disease that requires treatment and preventative treatment interventions. So what that means is you have a disease that's expected to last over 6 months that's going to have periods of exacerbations and remissions, complications, and needs to be treated. What happens with patients that seek treatment for this is they face a lot of bias and discrimination. I'm pretty confident, and I feel very strongly that the reason we're here having this conversation is discrimination against people that have obesity. What happens is these patients have inferior health care when compared to those of normal weight. There's some research out there that shows that patients that are affected by obesity, on average, spend less than 7 to 15 minutes less with their primary care provider. Patients that have more chronic issues, they get less time. So this inhibits them in seeking medical care and starts that cycle of worsening chronic conditions without improvement. Risk factors for obesity, like every other chronic disease, there are risk factors: genetics, medications like steroids, and drugs used to treat many psychiatric conditions, mother's pre-pregnancy weight, metabolic rate, lack of sleep. There's a long list there. If you notice, unhealthy diet is at the end. Guys, we could all eat better. We could all move more. And if you don't think that's true, keep a 7-day food log and bring it to me, and I'll be glad to prove you wrong. We know that obesity in adolescents are increased by 15% over the last 30 years. Adolescents that are affected by obesity grow up to be adults that are affected by obesity. These adults have children. This is a cycle that we can't break without having some type of help. I want to talk about a real life patient that I have. This is a woman that I met a couple weeks ago. She's a 42-year-old Black female public school teacher. She wasn't overweight as a child. This is not a lifelong battle that she's had, but now her BMI is 45. She weighs 263 pounds. This is classified as class 3 or severe obesity. And I'll talk about cost in a little while and how much that goes up with the different classes. This is a woman that had COVID, and after COVID or any other viral trigger, sometimes we can have autoimmune diseases manifest. So she manifested autoimmune hepatitis. This is not something that she got from sitting in the KFC parking lot or from a lifestyle choice. This was something that happened to her. In the treatment of this, she was started on prednisone, 30 milligrams. That's a big dose of steroids. Anyone that's ever had to take a steroid dose pack and gain 10 pounds, this lady is living this life for the last 2 to 3 years. They were able to wean her down, but she's continued to gain weight. She's also an immunosuppressant that's associated with weight gain. The code for this is drug-induced obesity. She's now on 3 medications for hypertension, has sleep apnea, and chronic knee pain. For every pound over 200, it's like 4 extra pounds of pressure on your weight-bearing joints. So I talked to her about her diet and her habits, nothing truly alarming. I talked to her about how she was going to have difficulty with increasing her physical activity with her health conditions in her knee. And then we talked about, other things that she's tried, multiple things to lose weight. Patients come to see me, I have a page that I have them fill out. I put everything I could think of for weight loss on there, and they circle the whole page, and then sometimes they write things in I've never heard of. Her coverage options, because she's a state employee: 1 visit with a registered dietitian per year, a phone health coach, or bariatric surgery after 6 months of medical weight management. So if she's gaining, let's say, 10 pounds a month on this high-dose steroid, she's going to be 60 pounds heavier in 6 months. Surgery is going to be difficult because they have to go under the liver to get to the stomach. So she's likely to have complications from that. And she doesn't want to have surgery. Other options, the phone health coach, I think that probably does have a place. I think it's valuable. I think I would probably benefit from having a cheerleader call me once a week to give me a pep talk too. 1 visit with a registered dietitian. I've got 2 types of patients. I've got a patients that honestly could see that registered dietitian once a week, once a month, probably for the whole year. And I've got some patients that really could make it without it. And I think with some guidance, she was one that could make it without it. So what did I do for her? A whole lot of nothing, unfortunately. I encouraged her to reach out to her benefits administrator. So Mr. Emmerich, if you got a call from her, that was me that encouraged that. I said, call the state insurance commissioner and talk to him about discrimination against obesity. So Mr. Shaney, if you got a call, that was from me. And I also encouraged her to reach out to her House rep and her senator, because I really feel like This is a patient that I could have made a difference in, but I don't have access to the tools that she needs. There are over 200 comorbidities that are associated with obesity. What we do as providers is we put Band-Aids on these. We patch them up long enough to make it another month, maybe keep them out of the hospital for the rest of the year, but they worsen. Some of the most common ones we think of: hypertension, high cholesterol, osteoarthritis, sleep apnea. Pregnancy complications is a big thing in a state that we have such a unfortunate percentage of women that have pregnancy complications. The state does not cover weight loss for these patients prior to pregnancy, even though that we know that would produce a healthier pregnancy. It does cover sterilization. We also have data that shows that we have decreased work productivity and increased work absenteeism. Yeah. All right, so another real life example. I have a Jackson Public School teacher. I don't know how many people are clamoring to work in the Jackson Public School system, to be honest with you. She was referred to me about orthopedic surgery. I get a lot of referrals from orthopedic surgery. She needed a knee replacement, but she was told she'd have to lose weight prior to the surgery. Her BMI was over 50. Now, this is not a shame on ortho for not helping these patients. After a certain point, they could do the surgery, even though it'd be higher risk due to the weight. They wouldn't be able to do the physical therapy to recover from it. This patient also has an insurance exclusion for anti-obesity medication. So her options, once again, one visit with a registered dietitian once a year, her health phone care coach or cheerleader, as I call it, or bariatric surgery in 6 months. Now, she had a sister that had gastric bypass about 20 years ago and had horrible complications and eventually passed away from that. Bariatric surgery today is a different thing than it was 20 years ago. I'm a big fan of bariatric surgery. I strongly feel like you should continue to cover that, but I understood why she was not interested in that. Unfortunately, I didn't have any other options to offer her. So when she left my office, she was very upset that she was faced with probably going on disability. Oh, I left out an important part of the story. This public school that she worked at, apparently there were some stairs that she was having difficulty ambulating up to get to her job. There are 13 different types of cancers that are associated with obesity, and it accounts for about 40% of all cancer diagnosed in the United States. So although we're seeing decreases in overall cancer rates, we're seeing increases in cancers that are associated with obesity because our obesity rate is going up in the US. All right, so the statistics are pretty overwhelming, but I'm going to go over a few of them. This is a public health emergency that we are not addressing. 22% of adolescents are affected by obesity, higher in the Hispanic and Black population, highest in lower and middle income groups. In Mississippi, ages 10 to 17, 22.3% in the overweight or obese category. In high school students, we're first in the nation, and that rate has climbed since 2013. It's estimated that 93% of people who live with obesity have unmet medical needs. So I know this is tiny and the graph is hard to look at. What it's looking at is the obesity breakdown by race. And we do see a disproportionate amount of Latino and Black citizens that are affected by obesity, highest in Black women. Once again, lower incomes, racial ethnic disparities, and the rural health areas and counties. At your last meeting, someone talked about concern about hospitals closing down in these areas. These patients have less access to health care in these rural areas. They also have less access to healthy options. A lot of my patients that are driving from a rural area might be grocery shopping at Dollar General. They don't have access to the things that we have here. It's a little bit easier to look at. This is the obesity rate across the nation. You can see how it's increasing steadily. In the recent years, it's been quite a jump. Mississippi's obesity rate is estimated to reach 66.7% by the year 2030. That's data from the Mississippi Obesity Action Plan that was published in 2018. I know that's a little dated now that we're in 2023, but I wanted to use the State Department of Health, our state of Mississippi plan information, so you know I wasn't just pulling these stats from just anywhere. Over the next 20 years, Mississippi's obesity rate could contribute to over 400,000 cases of type 2 diabetes, over 800,000 new cases of coronary heart disease and stroke. You can see how it goes on, and over 100,000 new cases of obesity-related cancer. The CDC estimates that over 600 to 700,000 Mississippians are on the path to developing diabetes, and the average cost of treating diabetes alone is almost $17,000 a year. I'm going to tell you right now, I see these patients. I'm in an endocrine clinic. They don't just have diabetes. They have hypertension. They have knee problems. They have hyperlipidemia. They have sleep apnea. The list goes on and on and on. In Mississippi, over half of all deaths are attributed to chronic diseases. These are the chronic diseases: heart disease, cancer, stroke, diabetes, and hypertension. Obesity is a root cause of all of those. So we can either work on preventative measures here and start using pharmacotherapy, bariatric surgery, aggressive lifestyle, all hands on deck, or we can keep seeing these numbers go up. All right, so last meeting, it was mentioned that we should maybe look over and see what other states are doing, specifically look and see what Alabama is doing. This is ranking our states in obesity. We float back and forth between being number one and somewhere in the top 3 or 4. When this data was collected in 2020, we were number 1. Alabama was number 3, Louisiana number 4. So I can tell you what they're doing in other states, not much better than we are. They don't have it figured out either. I don't think that this is accurate. About 10 state plans and 19 state Medicaids have some form of anti-obesity medication coverage. I was doing some research this morning and talking to some other people, and I think that's actually closer to 20 state plans. There's been some changes since I originally made this slide back in December. Also wanted to look a little bit further at Alabama and Louisiana, our neighboring states, and compared to Mississippi. We are worse with social determinants of health index. We have more food insecurity. We have a higher poverty rate. And the poverty rate for Black residents compared to white residents, 161%. Remember what I said, there's a racial disparity in treating obesity. All right, so let's talk about expectations. This is from the Healthy You that I found online. It's a big Blue Cross push to do this Healthy You to track these numbers, including blood pressure and cholesterol numbers and BMI. The reason we track these because they kind of all lump together in what we call metabolic syndrome, which we know increases risk for cardiovascular disease and diabetes. What are we doing with these numbers that we're tracking? We can't treat it. It's estimated that only 20% of US adults have optimal metabolic metrics. All right, so I love this little infographic. It's the tug of war of weight management. I get a lot of pushback from people that say, well, if they take that medication or if they lose that weight, they're just going to gain it back. So I want you to know that there's a thing called metabolic adaptation that happens when you lose weight. When you decrease the calories that you take in, you increase your physical activity, your body reacts, and your metabolism slows down, your hunger hormones increase, and your fullness hormones decrease. The body is designed to gain weight. I have high blood pressure. Whenever I stop taking my high blood pressure medication, my blood pressure goes back up. I think that's pretty self-evident. So the pharmacotherapy, yes, they may need it lifelong, but it's either that or a lifelong history of over 200 comorbidities. It's estimated that over 70% of the body weight is genetic or inherited. So these, once again, there's a lot of factors there that the patients don't ask for. It's not a lifestyle choice. All right, let's look at current Blue Cross Blue Shield Mississippi coverage as best I've been able to determine. This is copy and paste from the online formulary and plan. At the last meeting, somebody asked, do you have to have diabetes prior to having treatment with these life-changing medications? The answer is yes. Obesity treatment or weight loss therapies and prescriptions are not covered regardless of any claim of medical necessity. So that patient that I talked about earlier that had autoimmune hepatitis and was on treatment that was inducing a significant amount of weight gain, there's nothing I can do to help her. They do have a weight management program through Active Health. If the BMI is 30 or greater, we should be helping people before they're overweight. We should have a preventative option here. They offer a 12-month program that provides individual counseling over the phone with dietitians, nurses, fitness experts. And this is available to participants at no cost. I have not found a patient yet that is doing this. And I think that it probably does have a place with helping these patients. But there's also a disclaimer on the Active Health Management's website that program is not a substitute for the medical treatment or instructions provided by your healthcare provider. So what I have to say about the treatment options for my patients, I don't have a say. All right, other options, registered dietitian once per year under preventative services. Like I said, I have patients that are in two groups, basically. One that probably can make it without the dietitian, just a little guidance. Another that probably needs to see them every month. We don't have a dietitian in our clinic because it's not reimbursed, so we can't afford one. They do pay for bariatric surgery. Once again, I'm a big proponent for bariatric surgery. Please continue to cover that. That is the right option for the right patient. I will use myself as an example. I worked with bariatric surgeons for 2 years prior to working in endocrinology, and I had bariatric surgery about 6 years ago. It was the best thing for me at the time, and I would not take it back for anything in the world. For these patients to have bariatric surgery, they have to be 18 or over. Their BMI has to be at least 35 with comorbidities, or 40 regardless. If their BMI is 40, they have comorbidities, whether they're diagnosed or not. They have to do 6 months of comprehensive multidisciplinary weight loss program prior to surgery, and they also have to have medical or agree to be medically supervised for at least 1 year post-surgery. The expectation for bariatric surgery is that it's lifelong follow-up. Complications can occur at any time. And so it's more than just a one-time cost. All right, whatever happened to prevention? Obesity prevention efforts have been insufficient for decades. If we were able to perfect how we could prevent obesity, we would not be at the state we are. Even successful studies like the Diabetes Prevention Program are hard to translate into the community. There's a lot of things about that program that work. There's a lot of things that we're not set up for. They had vouchers to give people for incentives. They had extra resources that we don't have. So once again, when you have these pre-existing disparities in obesity rates by race, ethnicity, socioeconomic status, they complicate this issue. Now, this is what probably y'all are really worried about. It's expensive to treat. All of these comorbidities are expensive to treat. None of them are cheap. But ignoring it in the long run is not going to reduce cost. It's estimated that there's a 40% increase in medical costs per year in people that are affected by obesity over a person with normal weight. It was mentioned at the last meeting, I think, that the cost goes up, 20% year after year? Maybe this is where your 20% is coming from. There's also workforce cost. At a national level per worker, job absenteeism rises with a degree of obesity, up to 7 days or more. Annual U.S. productivity losses are averaged between $13 and $26 billion. So Mississippians that are already at low income probably will find it difficult to continue to maintain employment with poor baseline health due to excess weight, multiple related health conditions, and also these additional healthcare costs and lost productivity. Now let's look at the potential impact of treating obesity. This is from, once again, the Mississippi Obesity Action Plan. If the body mass index of Mississippi was lowered by 5%, Mississippi could save 6.9% in healthcare costs, which at the time, based on data from 2008, would equate to savings of $6.12 trillion by 2030. The number of Mississippi residents that would be spared from developing new cases of major obesity-related diseases. Pretty astounding. 86,000 spared from type 2 diabetes, estimated over 66,000 from heart disease and stroke. And the list goes on. And also weight loss in childbearing women and men with overweight or obesity will likely reduce generational obesity and metabolic disease in future generations. This is how we get in front of this epidemic. All right, so this is looking at a study that was done on direct and indirect costs of obesity among privately insured in the United States. They did it focused based on industry. They looked at over, I think, 19 billion administrative claims nationwide, narrowed the pool that they wanted to look at down to 86,000. And they also had some data from short and long-term disability claims to compare this with. So they average direct medical costs for class 1 obesity, BMI 30-35, $1,775 a year. Class 2, $3,400 a year. Class 3, over $11,000 per year. So the highest total indirect and direct costs were observed in the government, education, and religious services group. This was compared to people in food service and other industries. Class 1, close to 15,000, class 2, 25,000, and class 3, $34,000 per year. This looks at what that breaks down to. The green, kind of that pale green color, is that loss in productivity cost. I was able to present for the Mississippi Medicaid Committee, and I know that's a whole apples to oranges thing, but Mississippi Medicaid had some data out there on their website where they were increasing counseling efforts and prevention efforts year after year, and we were also seeing obesity increase year after year. So assessment and counseling consistently increased, but the obesity rate and cost also increased and did not improve. Our current plan is not working. This is from the board report. What they did was they went back for Medicaid and they looked at off-label prescribing. So what I mean is GLP-1s, the medications that we use for obesity that are highly effective, the brands that are FDA approved for diabetes. And they looked at these medications that were FDA approved for diabetes and being prescribed to patients that did not have a diagnosis of diabetes. There was an initial increase in cost. And then at the end of the year, what they saw was lower medical costs. Even though the pharmacy costs were higher, it was only a $17 difference. Now, I know that sounds fantastic, and it does. And I know we have to factor in that the discounts that they get from their PBM will not be what we get for state employees. But it is encouraging to know that medical costs did go down in these patients, even though there was an initial pharmacological increase. Another thing I want you to consider is that state employees do not have access to basic standard of care for obesity treatment. This is a short list. There's a longer list of agencies: the American College of Cardiology, the American Heart Association. The Academy of Pediatrics recommends treating obesity with pharmacotherapy off-label if needed, as young as 8 years old. The Endocrine Society, GI Society, all of these, and I'll save you thousands of pages reading, say to treat obesity with comprehensive treatment plans, including medication. So our standard of care, like I said, is a comprehensive plan. Diet, lifestyle, pharmacologic interventions or medications, surgery, all of those are tools. We have to have the right tools to help these patients. So I'm gonna go back to the Mississippi Obesity Action Plan. Goal 4 of this plan from State Department of Health, our state of Mississippi, was to encourage healthcare professionals to adopt standards of practice for treatment to help patients achieve and maintain a healthy weight. I don't know what happened to this action plan, but I don't think we're using it. All right, just want to bring your attention to the Mississippi House Resolution 43 that we got this year. This was a resolution supporting the screening and treatment of metabolic syndrome, which includes obesity. It supports the practice of following current clinical practice guidelines. It supports efforts to remove barriers to treatment, including lack of insurance coverage for treatment options for obesity. All right, so standard of care medications, let's take a look at those. This is a graph that basically shows there are improvements in weight. With improvements with weight as low as 2.5%, we see improvements in health. When we get up to a weight of 10% or more, we see vast improvements. Over about 16%, we start to see overall reduced mortality and reduction in cardiovascular risk. All right, so these are some of our non-surgical options in mean weight loss. I tried to put all the medications I could think of on there. These are all medications that I use in my practice. Wegovy we see is a 15%. Remember I said somewhere in there, and it's more 15 to 18% depending on how long they're on it. Tirzepatide is Mounjaro. It is not FDA approved for weight loss, but it was mentioned at the last meeting. I think somebody had a neighbor that called them panicking because they were off of it. Welcome to my world. This happens all the time. It is expected to be FDA approved from what I understand sometime in the next few months, and the weight loss from it is phenomenal. Imcivree is for genetic obesity. I put that on there because I just wanted to remind y'all that there are other sources of obesity that are not just poor diet and exercise habits. So when we do that cost comparison that y'all talk about with bariatric surgery, and we look at weight loss, we hear things like, oh, with bariatric surgery, you lose 60 to 70% of your body weight. That sounds amazing. When we're looking at bariatric surgery, those numbers are in amounts of excess body weight. So if you have 100 excess pounds to lose, they estimate you'll lose 60 to 70 pounds. When you translate that into total body weight loss, like we report for pharmacotherapy or medications, it's about a 30% weight loss. So our medications are getting pretty close to bariatric surgery weight loss without the surgery. There we go, sorry. Let's look at another patient example of mine. This is a 48-year-old white male that came in. He was also another patient I had that was on prednisone. He got started at age 18 for a kidney issue, and he was on it for about 20 years. He was lucky to get off of it. If you, in the first patient example, if you had a thought of, gosh, you should just stop that steroid if it's causing all this weight gain, probably would die at that point if she abruptly stopped from an adrenal crisis. So they have to be weaned off extremely slow. So this man has diabetes, high cholesterol, and obesity, BMI of 35, once again, not overweight as a child. His dietary recall was not as good as hers. It's high carb, but he didn't drink sugar sweetened beverages, which I think is the devil. He eats out 5 days a week, fast food sometimes. He's in healthcare, he's busy. We're running at the end of the day. We stop and go through the drive-through. We generally say, well, it had to happen. It was just this once. We start making excuses. He has 3 to 4 meals a day, usually snacks on sweets. In case y'all didn't know, when you work in healthcare, people bring you sweets all the time. We get lots of Krispy Kreme on our clinic on County Line. He's previously tried multiple diet and lifestyle changes, none of which have worked, except for some random diet I had not heard of that he lost 20 pounds that he did not maintain. All right, so this is a graph, and I know it's a little hard to read, but I copied and pasted this from my clinic EMR because I want you to know I don't make these patients up. These are real people. So he started in October of 2021 at 237 pounds. His A1C was 7.3%, so diabetes. I started him on Ozempic. This is semaglutide. This is a medication that's FDA approved for diabetes. Under a different name brand, it is FDA approved as Wegovy for weight loss. So we're talking about the same drug. He made some dietary changes, some lifestyle changes because he had this tool to help him make those changes. He started out on 2 cholesterol medications, and his cholesterol is, it's okay. So by August of 2022, right at a year, he was down to 188 pounds, blood pressure better than mine, and his A1C was 5.2%. And somewhere in there, he had stopped his cholesterol medication, and his numbers were, for the most part, better than they were on 2 medications, one of which he'd also been on for somewhere around 20 years. So we're talking about a 40-pound weight loss over 1 year. So about 20.7% of his total body weight loss. It's a little higher than we see in clinical trials, a little higher than I talked about earlier. I used to think I was really good at my job, and I was a rock star, and I was helping all these patients, and they were blowing it out of the water and losing all this weight, and I'm seeing 20-25% easy. And then I found out the clinical trials that we get these numbers from, their average weight is 231 pounds. My patients do not even know they're overweight at 231 pounds. So once again, we got him off of all of his medications, including long-term medications he was on for cholesterol, and he is only on Ozempic, and I do have him monitoring his glucose. All right, so let's talk about some barriers to treatment and some recommendations that I have for you. I think the biggest barrier to treatment in obesity in Mississippi is just the stigma and bias associated with obesity, lack of access to care. We have limitations on who can provide this care. So the State Medical Board and State Nursing Association limits who can treat obesity for how long. It's very structured. For instance, the State Medical Board requires that if over 30% of your patient population is on any type of weight loss plan, or you advertise for weight loss, that you go through their association and are registered as a bariatric clinic. So the medical director has to do 100 extra hours of obesity continuing education. That's a lot. They also have to reapply every 2 years. And to reapply, they have to have 60 hours of obesity-specific education. So even if we had coverage, every provider in Mississippi would not be able to offer it, which is a double-edged sword. That would reduce the onslaught of every provider in Mississippi would not be able to put every patient they have on an expensive medication. So it would help control costs somewhat. I talked about financial issues and food deserts and lack of dietary education. There's lots of different things that we have here that are barriers. Some recommendations, and this is from the Trust for America's Health Organization. The state of obesity is a big plan where they look at everything in the United States and go over that and make recommendations. Their recommendation is to adopt science-based recommendations or clinical practice guidelines on obesity treatment. I will save you from reading that document also. This is the best part. All healthcare payers should establish quality measures that prioritize screening and counseling to prevent obesity, and when necessary, to cover obesity-related services that meet the National Academy of Medicine Health Equality definition of providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, or socioeconomic status. This is a slide I started on about midnight last night and said I better stop. The cost is high for these medications, but the cost would be acceptable if it was any other disease process. And here's some examples. Hep C treatment, when I looked it up, about $28,000 for a 3-month supply. I don't know what y'all pay for it, just like I don't know what you would pay for the anti-obesity medication because it would be up to your PBM, but it's expensive. Other examples I just kind of breezed through and saw. Humira for rheumatoid arthritis, about $7,000. Very expensive to treat. If this was any other disease process other than obesity, it would be absurd that we're not treating it. All right, there's a lot of fear mongering about cost and we can't afford this. When we look at Medicare, that has a program that pays for intensive behavioral therapy. This is where patients can come and once a week for the first month, see their healthcare provider, then once every 2 weeks, then once a month, and have intensive behavioral counseling. It has been shown to be mildly successful. I think they have to keep off or lose 4 to 6% to continue it after 6 months. There's only about a 1% use of this. I talked about the Board of Medicine and how they limit who is able to treat obesity. So that's another limiting factor. We have seen other states that are covering anti-obesity medication. And from what I've heard, it's typically somewhere between a 2 and 4% uptake. So when we talk about obesity has a 40% rate in Mississippi, that sounds scary that we're talking about putting 40% of these patients on medication, but that's not what it would actually look like. We can mitigate the risk of excessive prescribing. There are different things that we could try to do in addition to the state licensing board restrictions. I do strongly encourage you to require prior authorization for coverage. And this won't be popular with my colleagues, but I think there needs to be an updated prior authorization every 6 months. We need to prove that these medications are working if we're going to continue paying for them. I think that we renew the PA only if a certain percent of the body weight is lost or they're maintaining within a reasonable goal. And I will say that while the label says to continue it, in my personal practice, my patients don't want to be on medication forever. What we try to do is wean down to the lowest dose. Sometimes we spread it out off label, but it does help reduce cost and it helps them because, like I said, they may not want to be on the medication forever. I think that another idea would be to accept the PA, the prior authorization, only from in-network providers. You could consider specific specialties, but I don't know if that would cause issues or not. But what I would be concerned about would be these pop-up shops that are only treating obesity. They're only basically paying for your prescription. I would be concerned about telehealth providers from out of state that are, seeing 30 patients in an hour and you're just filling out something to get your prescription. Y'all don't think those things happen? They do. I recommend that you cover these anti-obesity medication, registered dietitian visits, possibly more than once a year, and also cover them under adult wellness and preventative services, because your policy says that out-of-network preventative care cannot be covered unless it's provided in network. So that would be another safeguard to help keep this in network. All right, to summarize, and I know that was a lot of information, I really appreciate y'all once again. Obesity is a chronic disease. It's the root cause of over 200 comorbidities plus 13 different types of cancers. We as providers need the right tools to treat this root cause. There are a plethora of clinical practice guidelines and position statements from national organizations that support the safe use of anti-obesity medication. We've just got to take the obesity bias and discrimination out of healthcare and insurance perspective so that we're able to provide this. Obesity is killing us as a state, literally and financially. We've got to do something to get in front of it. There are strategies to limit prescribing to allow obesity specialists options, like with the patients that I discussed, they're in extreme need, without allowing overuse of this benefit. So once again, I do recommend that you try to cover anti-obesity medication, registered dietitians, continue to cover bariatric surgery, and I would consider doing these things as adult wellness or preventative services. Thank y'all so much. I would love to answer any questions that I'm able to.
Thank you, Ms. Davis. Do we have any questions from the members of the committee? Ms. Davis, if I may, the chair has one question. And as a policymaker, I'm trying to understand the big picture here. What are you telling us that every case of obesity is disease related?
I'm telling you that obesity is a chronic disease and that it leads to multiple other chronic diseases. There are many diseases that are related to obesity, such as, like I said, there's medications that promote obesity or weight gain.
The steroid example for the public school teacher?
The steroids are big ones, but sometimes they're just unavoidable. Antipsychotic medications.
That was going to, I hate to interrupt you, but that was going to be my question. There's an option to the steroid treatment, isn't there, for certain diseases and conditions?
So there may be an option for some patients if it works, but those options are very expensive and may not work for that patient. And once again, once they've been on, I think she was on 30 milligrams of prednisone for a year, it's a very slow taper. The body makes its own cortisol. You need that to live, and you may not.
No, I understand, but I'm assuming those options were tried by the medical provider.
I assume they were with her.
Okay.
She sees a liver specialist at UMC, so I assume that probably every possible option was tried.
Okay. And then secondly, on the drug treatment that you mentioned, and you touched upon this, eventually you want to reduce the prescription, the number of prescriptions over a certain period of time, or the volume, the dosage. So, but you never mentioned that drug treatment will ever stop. Is that the case? Once you're on it, you're going to have to be on it for the rest of your life?
So that is the general understanding. Like I said, in my personal practice, maybe a patient that had a situation like that didn't have lifelong obesity, that really was dedicated and wanted to try to reduce her medication. We may try to wean down or spread that out, but for the most part, yes, they will be likely on the medication for the rest of their life.
Okay, and the chair's last question for the benefit of the committee is what, and you may have touched upon this, but I didn't catch it. What is the main differences between the state's health insurance plan and the private sector in terms of treating obesity?
So in the private sector, we have a lot more options. Typically what I do when patients come in, I ask them, call and check with their insurance to find out what their cost is going to be and what's covered. So we'll know. So if they have state plan, I know nothing's covered. If they have private insurance, so patients with like Blue Cross Blue Shield of Tennessee that work at Nissan, they have coverage for anti-obesity medication, Comcast, another that covers. There's several private companies that do. What I get generally when I tell patients they don't have coverage, well, what companies cover it? Because I try to explain it to them that the company that you work for, the institution that you work for, they have to opt in for obesity treatment and yours has not opted in. So they want to know, well, who has opted in, presumably to maybe change careers.
So just to follow up then, what is, in your opinion, what is the number one major difference between the private sector and the state insurance plan in terms of treating obesity?
We have no options.
No
We have
options,
no
okay.
pharmacotherapy options whatsoever with state employees.
And then one follow-up, same question comparing the state health insurance plan to Medicaid.
So Medicaid has coverage now, starting July 1st for Wegovy, Saxenda, and Contrave. That they have coverage for these options. I think they generally have coverage for registered dietitian visits. And I don't know that there's a limit on that, but I could be wrong. They do not cover bariatric surgery, which many states' Medicaid plans do cover bariatric surgery. So it's a give or take. Neither plan has a comprehensive plan without all of the tools available. But I would say if I had to pick a patient that I was going to be able to actually help, Medicaid, because they have coverage of the medications that many of these patients would benefit from.
Okay, any follow-up questions from the members of the committee? Seeing none, Ms. Davis, we appreciate your time, your expertise, and your knowledge, and thank you very much.
Thank you so much.
Ms. Liz, you're up next.
Slides, I think everybody has seen these, and so we're not going to go over every single slide. This is just for your benefit. I think the board as a whole is continuing to look at weight loss and diabetes, and we're doing some research now. We know that Medicaid is now covering we say Ozempic, I think it's Wegovy for weight loss. We do cover that if your A1C is a certain level. Is it 37? So we do cover it for that, but we are not at this time covering it for weight loss, but we are beginning to do some research to see how much that would cost to do that. Bert is just going to go over some high points for those of you that don't know him. Bert Emmerich, he is the deputy at the health plan. Oh, sorry, deputy at the health plan.
Thank you, appreciate it. As Liz said, a lot of y'all have already seen these slides, so going to touch on some high points. If y'all look at slide 4. You see the state health plan currently covers 189 plus lives. 106 are active and COBRA participants and 51,000 are dependents. 18 plus thousand Medicare retirees plus their dependents. 7,000 plus non-Medicare retirees plus their dependents. That makes up the total coverage lives of the state health plan. As most of y'all are aware, there are the 2 types of participant types, legacy and horizon. Legacy, of course, has been sunsetted, and horizon is what is the current plan for most people coming on a state health plan currently. Moving on, the next one is talking about coverage options. The select coverage is about 1,800 deductible for family, 1,800 for individual, 36 for family. The base is 1,800 deductible for the individual and currently 3,000 for family, but 1/1 that'll increase to 3,200 as required by the IRS. And next 2 slides, you can see what our active employees and retired employees, what the most coverage is, what they're most covered by. So active employees are legacy, almost 50,000 are covered by the legacy select. And as you can see, the majority of the state health plan members are covered by Horizon Select, a little over 80,000 lives. And as I mentioned, the legacy plan is getting sunsetted. So as you can see, our retiree population, that is the majority of the retiree population, is the legacy select. Premium contributions, as everybody in here knows, that the state health plan is a self-funded plan. These are premiums paid for by our members, is what funds the state health plan. So the state pays full cost for active employees enrolled in base coverage. Employees may choose a select coverage and pay an applicable premium. Currently, legacy is $20, Horizon is $46. Of course, that rate will go up a little bit with the new rate change in 1/1/24. Employee pays full premium for their dependents, and retirees pay full premium for themselves and their dependents. Next slide you can see is the rate increases or the rate changes for 2024. Legacy, employee only, total premium is $459, the 0 employee portion. If you choose a select legacy or members that are still under legacy, $479 and the employee portion is $20. Currently Horizon, which is the majority of what the state health plan employees are under, if they choose the base plan, it's $459. Employee portion is 0. Under the select plan, which is what most members are under, it's $507 is the total premium, and the employee portion is $48. And you can see the rest of the chart is what the other coverages cover: employee spouse, employee children, child, and family. You see the rates listed there as well. And the next page just goes through all the retiree prices and premium coverages for 2024. I'm not going to go through them all here, but they're there for you to review. And historical premium rate increases from 86 through 2022. As you can see, we've had pretty much a rate increase just about every year since 1986. It's leveled out in the 20 teens, I guess you could say, but of course, the past few years we have had to increase the rates. At the last task force meeting, it was discussed comparison of our premium rates compared to other states. And these next 2 graphs, these next 2 charts will show those premium comparisons. Mississippi's listed as the top, as I mentioned, and this graph only shows our select plan in comparison to other states. So as you can see, that our total cost for premium for a single employee is $507, with the employee share of $48. state share being $459. The state share is 91% of that total premium cost. Staying within the single coverage, comparison to similar states or states on our borders, Alabama right below that, their total premium cost per single is a little over $1,000. Their employee share is $140 and their state share is $930. So their state share is at 87%. So as you can see, Mississippi is cheaper for total cost per employee compared to Alabama. And we do have a state share higher than what Alabama's share is for individuals only. If you look at that chart as well, a state that is very similar to what Mississippi does is North Carolina. Their total cost is of course higher than ours. Their employee share is very similar at $50 and their state share is $674 and their state share percentage is 93%. If you look at that same chart, employee children coverage, the total cost for employee children is $909. State share being $459, still the same, but the employees are responsible for $459. So the state share is 50% of that. And if you look across, if you look down that list, Mississippi is going to be the lowest on that list, unfortunately. But again, if you compare to Alabama, their total cost for employee child coverage is a little over $1,200. Again, their state share stays the same at $930. Their employee share is $330. So their state share is 74%. So again, the state that compares to Mississippi is North Carolina. Their total for the state, for the employee child coverage is $979. Again, their state share remains the same at $674.54. Employee share being $305, and their state share is 69%. I would guess the big one you want to look at is on the next page, if you turn to the next page, is the family coverage. Comparisons there. Total cost for Mississippi for family coverage is a little over $1,300. Again, our state share stays the same at $459. Employee share being $882 for a state share of 34%. Comparison, I know Alabama's next door to us. Their total cost for family is a little higher than ours, a little over $1,400. Their state share remained the same at $930. Their employee share is $490. So a state share of 65%. Again, another state, again, comparison to what we are in North Carolina, their rates are very similar to ours. They're a little over $1,300 on $1,400 of their total cost. Their state share again remained the same at $674.54. Employee share was $720, or a state share percentage of 48%. These three states, I point these out because these are the three states whose state share remained the same cost-wise over all coverages. The Mississippi stayed the same at $459, Alabama $930, and North Carolina at $674.54. All the remaining states on this chart, their state shares changed from state to state and coverage to coverage. And that's really all we're going to share with y'all today. Again, the rest of this chart, we've presented this before, so everybody should be fairly familiar with it. The biggest thing we just wanted to point out was the premium comparisons that was asked for in the previous task force meeting. Does anybody have any questions?
I believe that concern was expressed by the Senate Education Chairman. So can we make sure he gets a copy of this for his review? How, like, you may not be able to answer this, like Alabama, how are they able to keep the premium the same for the individual and the individual spouse compared to the family? I think there's maybe 3 or 4 states. Do you happen to know that by any chance? Okay.
We don't know how we've tried to find out, but Alabama's got their website pretty well locked down, so we can't figure out the numbers behind where they're pulling this stuff from. We're not sure even how they fund, if they're complete self-funded or not, or if they have separate funding. We're not sure that either.
Interesting. The contract for the pharmaceutical benefits, when is that up?
Yeah, I think we're in year 2 of 4. So 2 more years.
For
I
2
believe.
more years? And I guess does the RFP go out the year before or 6 months?
So then, yeah, the next RFP will go out within the next 4 years.
Sure. So the contract is up 2 years from now. So I guess the RFP would go up would go out anywhere between 8 to 12 months before the termination date. Okay. Any questions from the committee? Anybody on Zoom? Amy? Huh? Mr. Vice Chairman, you're recognized.
Thank you, Mr. Chairman. I have one question. What's the average age that's on our state employee health plan?
I don't have that readily available. I can find out what the average age is.
Because let me go back to the graph starting in 1986. Or how many employees that are retired are on the plan?
Sorry.
How many retirees are on the plan?
If I can go back to the previous slide. Yes. Yeah, 30,675. Yeah, thanks, Liz.
Thank you.
Anybody else? Ms. Liz, we understand and appreciate that your staff is extremely, extremely busy. So yes, we appreciate your time. Next up is Mr. Josh Golden. Mr. Golden, before you testify, please provide us some details concerning your background and the company you work for, please.
Good afternoon, everyone. Thank you, Mr. Chairman. My name is Josh Golden. I'm the Senior Vice President of Strategy with Capital RX. I'm not here to talk at length about my particular company, but just to provide a little bit of context. Capital RX is a transparent pharmacy benefit manager looking to fundamentally change the way drugs are priced and patients are cared for here in the United States. We have grown quite a bit in our 5 years of existence as a newcomer to the PBM space. So we currently service patients across all 50 states, have clients all across the country, including right here in the great state of Mississippi. We service, by way of example, the electric cooperatives of Mississippi. They've been a client of ours since September of 2022. We actually have a handful of other Mississippi-based employers coming on board with us for 1/1/2024. Prior to my time with Capital RX, I've been with the company about 4 years. I actually spent about 20 years as a consultant in the benefits industry, focusing narrow and deep on the area of pharmacy benefits, helping large, complicated plan sponsors navigate these, let's be honest, these murky waters of PBM land. I helped with procurements for Fortune 500 companies, as well as public entities, county governments, school districts, labor unions, et cetera. I also helped implement pharmacy benefit management arrangements and helped to audit them. So I've seen this industry from a number of different perspectives. Yes, sir.
Any state governments?
In my time as a consultant, yes. Capital RX doesn't currently support any state governments.
Okay, and then where's your company located?
Yeah, we're headquartered in New York State. Yeah. Again, my experience as a consultant and now my experience working on the inside of the pharmacy benefits industry gives me a unique vantage point to understand everything that is good, bad, and ugly about our drug supply chain. And part of what has made me, and that experience is part of what has made me very passionate about what I'm here to speak with you about today. I'm going to start if okay with you, with kind of a fun little exercise of what I call 2 lies and a truth. So this is 3 widely held beliefs about healthcare, the first 2 of which are not at all true, and the third of which is an absolute truth. The first widely held belief is that pharmaceutical companies control the price of drugs. And I regret to inform you that's actually not true. Pharma companies set the initial price of drugs, the list price, but the price of drugs that is paid by the patient and by plan sponsors in the United States is largely determined by intermediaries and primarily by the pharmacy benefit manager. The second widely held belief is that doctors decide which drugs a patient ends up with. And while it may be true that the doctor writes the initial prescription, just like the pharma company sets the initial price, the ultimate drug that the patient ends up with is highly influenced and in some cases mandated by the pharmacy benefit manager. Again, that powerful intermediary within the supply chain that controls utilization through things like formulary utilization management and other features. The third widely held belief is one that is an absolute truth, and that is that in healthcare, incentives matter. And by that, I mean, if you want to know how a healthcare vendor is going to behave, how they're going to manage a state employee plan, for example, then you need to understand how that vendor makes money, because that will be the single most powerful force that drives their behavior. This is the world of drug costs that we're experiencing as a country right now. Costs have been going up steadily for the last 2 decades. Pharmacy benefit managers were tapped as our advocates, our stewards, to help us try to tamp down costs as plan sponsors and patients. And if you look at the strategies that they've introduced over the last couple decades, first with the explosion of mail order and specialty drug fulfillment operations, next with the introduction of managed formularies, where they started to exclude drugs from formularies to steer patients towards more highly rebated products. And most recently, the vertical integration between the large PBMs and the largest carriers in the country, you start to see a pattern. And that is that these 3 strategies ultimately have served the interests of the PBM. It's questionable whether these strategies have actually driven down cost for patients and plan sponsors, but it's very clear that these strategies have added obscurity, complexity, and nuance to the way that PBMs make money in the United States. And so part of what I'm going to do today is unpack that for you and share with you sort of my expertise around how I understand this business to work. This is the landscape as it stands today, driven largely by acquisition and merger. We have 3 entities that dominate the PBM landscape. And this is a really important chart to understand in terms of the way PBMs now, these large PBMs now have to think about the landscape and the industry, because they have essentially gotten too big to get any bigger. And by that, I mean, the Federal Trade Commission is not going to allow them to acquire anything of meaningful size to grow in terms of M&A. And so, and let's be honest, the 3 of them control about 75, 80% of the market. So they can't really organically grow much bigger, which leaves them with an interesting challenge. And that is that they have to demonstrate returns to Wall Street on a relatively stable member population. And the only way they do that is by figuring out how to make more money off of the existing patients that they serve. Now, PBMs have not always been the complicated machine that they are today. So we're going to take a quick walk through the history of the PBM model. And it starts with the PBM as a plan administrator, operating on a fee-for-service basis back in the late 90s. This is how most of them functioned. And negotiating at arm's length with entities up and down the supply chain, like pharmaceutical companies and retailers, et cetera. But PBM soon realized in the early 2000s that there was a lot of money to be made in dispensing. And this is that first mega strategy that I mentioned in my earlier slide, that most of them either acquired or built out mail order and specialty dispensing facilities and started reaping some dispensing profit from those operations. Some of the PBMs aligned themselves by ownership with retail pharmacies. There were a handful of these that existed in the industry and continue to exist. And more recently, PBMs formed what are called group purchasing organizations or rebate aggregators. This is essentially a separate spin-off LLC company, a subsidiary that sits organizationally separated from the PBM as a safe haven for receiving rebates, retaining some margin on a more opaque manner, and then passing some portion of rebate flow back to the PBM and ultimately, hopefully, the plan sponsor. I mentioned the vertical integration in which PBMs align themselves with the large national carriers. You can start to see the PBM business model taking the shape of an amoeba or an octopus, right? With arms reaching out in different directions. Each arm that reaches out is another source of profit, most of which are not fully disclosed to clients. Most recently, we have PBMs that expanded into PBMs and carriers, the vertically integrated carriers that expanded into the ownership of provider groups, the actual physicians. I call this the last mile of influence for healthcare, because when a carrier PBM entity has contractual influence over a provider, a physician, they can now steer the way that physician behaves. For example, how they prescribe drugs. The end result of this evolution is a profit model for the typical large PBM that is both highly complex and potentially very conflicted. Now, here's an array of ways that a PBM can make money. The ones on top, the green segment, are pretty straightforward. They charge a fee, they provide a service, fee for service arrangements are somewhat common in healthcare. But everything down below that green section is mired in shadow. We've got spread pricing tactics in the retail setting, in which these are all various tactics that allow the PBM to charge a client and a patient more than what they actually reimburse a pharmacy. Mail order and specialty dispensing profit, which I mentioned earlier, and the quiet retention of pharmaceutical company revenue, which we casually call rebates, but is actually comprised of a whole wide array of revenue streams that change hands between pharma and the PBM. What is basically going on here is a dual ledger system. Okay, so the PBM, typical large PBM, manages, in essence, two books. On the right is the ledger of pricing that they negotiate with the supply chain, with retailers, with pharmaceutical companies. And on the left is the ledger that they decide to offer to each one of their clients. For example, the state employee plan. That ledger on the left is different for every single client. So that's the first important fact we need to understand and acknowledge, is that PBM is a price determiner or a price discriminator by client. They will give one price to one client and a different price to a different client, even if the back-end economics that they're getting from the supply chain are exactly the same for those clients. Now, this is really important across the drug spectrum, understanding this dual ledger concept, but it's immensely important when it comes to specialty drugs. And that's because specialty drugs are the fastest increasing segment of drug utilization in terms of cost. And PBMs have enjoyed what I would call a triple tailwind of financial benefit from specialty drugs. And that's because, as I mentioned, PBMs now own the majority of the specialty pharmacy utilization in the country. Utilization is going up because new drugs are coming out and new indications are being applied to existing products, et cetera. The unit price of those drugs is going up either through inflation or because the new products coming out are just more expensive. And most important for the PBM, the pharmacy benefit manager has been incredibly successful at capturing specialty drug utilization, taking it out of the retail pharmacy setting and placing it within the walls of their own dispensing assets. This has created a sort of a triple tailwind, as I mentioned, that has made specialty pharmacy an engine of profit growth for the large PBMs. And those PBMs in turn are an engine of profit growth for the carriers that they're affiliated with. So even though pharmacy is 25 cents on the dollar typically for a healthcare plan, the profit margins for most of the vertically integrated carriers for pharmacy represents in some cases half or more of the profitability that they enjoy. And as a result of the aggregation of this volume, you can see that the specialty pharmacy marketplace, the dispensing marketplace, largely mirrors the dynamic of the PBM industry. And so you have two industries that are basically now in lockstep. They are, in essence, one and the same. Now, to understand, I've talked sort of notionally or sort of in abstract about how PBMs make money. And I thought I might make this real with a tactical example. This is what I call a journey of profit that a prescription claim goes through as it moves through the system. I've chosen Humira here as an example of an expensive specialty drug, but you could really choose any specialty drug out there and the result would pretty much be the same. The prescription is submitted to the PBM. The PBM channels that prescription to their own specialty pharmacy, and they charge an admin fee. That's the first source of profitability. They likely will apply a prior authorization to that product, and typically the plan will be charged for the prior authorization, regardless of whether it's approved or not. And I'll talk a little bit about those approval patterns in a moment. Next is a copay card, which is often applied. This doesn't always apply to things like Medicaid and Medicare, but in the commercial space, most specialty drugs do earn a coupon, and that coupon is administered by the PBM at a pretty hefty fee. The PBM will usually keep about 25 to 35% of that coupon value. Next is the big payout for the PBM. The specialty drug is dispensed from their pharmacy. They earn dispensing profit on that. Next, a clinical program is initiated. Now, this sounds good, right? A patient's on a drug. You want to make sure that they stay adherent. You want to make sure they're managed. The challenge with this funding is that it largely comes from pharmaceutical companies, and it is very difficult to track, which means that the PBM has the chance to use this funding as another profit center within their enterprise. A rebate is paid about 6 or 9 months after the drug is processed. The PBM takes a portion of that rebate. Even plans that believe they're getting a full pass-through of quote unquote rebates under their PBM contract are likely not receiving that. And that's because the rebates are very narrowly defined within those contracts to only include certain revenue streams. And then whether or not you know it, that data, your utilization is being sold back to pharmaceutical companies at the end of the year. PBMs compile this, and pharma is very hungry to learn about utilization patterns, dispensing patterns, and things like that. Now, this is 7 different ways that the PBM has earned profit on a single claim for a single patient. I've highlighted 5 of these in red because they're the ones that concern me the most. These are the sources of revenue that are directly tied to drug price. And that gets at the heart of the conflict of interest that exists within our supply chain right now. And I'll sum it up in the very simplest of terms. If you're with a traditional PBM, then your PBM makes more money when you, the plan sponsor, or the patient, spends more money. It's as simple as that. The way that the business model has diversified ties the PBM's profit directly to the price and volume of drugs, meaning that their very financial survival depends on their clients paying more and more every year. And they have the ability to influence this. Now, this chart is a little bit, maybe a little busy to start out with, but I'm going to walk you through it because I believe it's a very, very important example of how PBMs, through their day-to-day decision-making, can create waste and introduce excess costs within the system. The way that you read this chart is that this is a chronological series of fills, prescription fills for a single patient, right? So each blue bar represents a single prescription fill of about 30 days for, in this case, Humira. Single patient, single drug again, right? The light blue portions of the bars are the overlapping portions. This is where the PBM specialty pharmacy has reached out a little bit early, before the end of the next month, to get that patient that drug a little bit sooner. Now, this is good, right? You want that patient to have a little bit of extra drugs, a little bit of extra supply, if you will, for that drug in their medicine cabinet in case there's a storm or we can't get their drug for some reason. But look at the pattern of dispensing that occurs with this PBM. Every month, another 7 days early. Every month, more days supply in the medicine cabinet of the patient for a very, very expensive drug. By the end of the year, you can see that this patient has 113 extra days supply that has been sent to them. In most cases, patients aren't asking for this. It's just showing up at their doorstep. And if you talk to most patients that sign up for mail order, most of them will tell you by the end of the year, I've got 3 extra pill bottles in my cabinet and I didn't even ask for them. I've got more drugs than I need or know what to do with. And the cost for this can be substantial. The cost for this particular patient was about $25,000 of excess supply. Now, this is Humira, a refrigerated drug, which eventually, unfortunately, will probably just be either thrown out or will go bad in the patient's refrigerator. If you take this and multiply it out by the number of patients that a given plan has on Humira or other expensive specialty drugs, you can see the tremendous potential for waste. And the reason that a PBM would do this, they would set their refill protocols like this, is again because their profit is tied on moving that merchandise out of their specialty dispensing facility. There's another example, same concept. I'm just going to go over briefly this one because it's really telling. The top 6 fills all occurred at retail, and you see that the patients only acquired a handful of extra days' supply. This is what happens when patients are taking a drug and they go to the pharmacy efficiently and they get the drug when they need it. Unfortunately, in this case, the drug was moved over to the specialty pharmacy owned by the PBM, and the end result, you can see the early refill kick in again by the end of the year. Again, a tremendous amount of about 69 days supply excess at a very significant cost. This is for a breast cancer medication. We want the patient to have this medication, but having 69 extra days of this drug in their medicine cabinet is not going to cure their breast cancer any sooner. Now I mentioned, so that's an example how PBMs can manipulate the volume of drugs, and plan sponsors unfortunately aren't really even aware of these mechanisms. They just sort of sign up for programs because PBMs recommend them. I mentioned the volume of drugs. This is a way that PBMs manipulate the mix of drugs. Prior authorizations are an important gatekeeper function. I think the prior presenter on GLP-1s and weight loss medications mentioned, even recommended that PAs be an important tool in ensuring that utilization is appropriate. Most managed care pharmacists will tell you that for any mix of prescriptions for a drug that's prone to off-label use, you should only really be approving about 60 to 75% of those prescriptions coming through. Which is not to say that the patient doesn't get a drug. A successful prior authorization control is one that gets the patient on a lower cost medication, one that saves the plan and the patient significant dollars. But what plan sponsors see when they ask for PA approval rates from their PBM for their plan, they're often shocked to see that the PA approval rates often hover in the high 90, sometimes 100% of claims just being waived through, right? And this isn't good gatekeeping. This isn't a responsible stewardship of the plan's limited assets. And what's more, it doesn't drive the best outcome for the plan financially. What it does do is it helps the PBM secure higher rebates for the drugs, because if they promise to leave those gatekeeper functions loose, if they commit to the pharma company that they will leave that gate essentially open, the pharmaceutical company will reward them with a higher rebate value. And as you can see in this illustration, and this is a theoretical illustration, but the numbers hold fast when applied to real life, you can see that even with a higher rebate value, if that PBM is waiving a greater percentage of PAs through, the end cost for the plan for every 100 prior authorizations is going to be higher than it was. So I'll pause here for a question.
I hate to interrupt you, but I'm not following you. That 60-day additional supply for that patient that you mentioned may be thrown away, that prescription has to come from the doctor. I mean, it's not the PBM's fault. So why is that prescription being written?
Yeah, again, it goes back to my earlier point, which is the widely held belief that doctors control prescriptions in the United States. And the truth is the doctor writes the initial prescription and they designate how many refills the patient can get, but the doctor doesn't decide when that refill can get sent. It's the PBM and it's the PBM that decides that.
So you're telling me that the PBM has the authority to decide over the doctor when that prescription gets written? I don't think that's the case.
Not when the prescription gets written. One prescription is written, which includes refills for the remainder of the year. That PBM decides when the refills go out.
Okay, thank you.
Sure. Just get back to the slide here. Sure, yeah, and absolutely. Happy to pause and fire questions away as they come up. Yeah.
Bob, use the microphone, please.
So I want to follow up on the chairman's question. So a 90-day supply of, let's say, high blood pressure medicine. And before that'll fill again, are you saying that the PBM will say 3 days or you get more, or, I mean, expound on what you said.
Sure. The prescriber writes a prescription, not for a single fill, but for a fill followed by a number of approved refills. And it's usually for a long-term maintenance medication, can be a prescription that lasts up to a year. So when you get a prescription, that piece of paper, and you take it to the pharmacy or send it off to the PBM's pharmacy, that pharmacy is then authorized to dispense the initial fill, as well as however many refills are written on that prescription.
I don't think that's the case in Mississippi. I think the PBM will contact the provider and tell that provider as to when that prescription may be getting to the point where there's no more medicine left. But I think the prescription, the renewal also needs to come, Mr. Golden, from the doctor. The PBM can't make that decision in Mississippi.
The initial prescription absolutely must come from the provider, but it includes a number of refills that are authorized. No, for example, if it's a 90-day supply, let's say it's a 30-day supply for the initial fill, right, of a specialty drug, that would be 2 vials of Humira, for example. They will then say that this patient can get up to 11 refills on this. Yep, and that would, each refill would represent another pair of vials. Or if it's pills, let's say it's 90 pills for 90 days, this patient can get up to 4 refills. The next refill would be another 90 pills. A new prescription is typically not required unless the physician has said only dispense 1 fill, no refills allowed.
Okay, so if let's say a doctor prescribes, let's go with a year or 360 days. So initial plus 11 refills. And you're saying they're sending the pills early and they're stockpiling them and they're making money off of that. Well, after 360 days, they've got to go back for another prescription to the doctor?
It depends on how the prescription is written, but
Okay, because it would seem like at that point, you have the accumulation of pills and you would use those for the rest of the year and start over.
yeah.
So I don't see how getting them there early makes money for the for the PBM.
Well, at that point, if the PBM does reach out to the physicians typically will just approve additional refills.
Like
They'll
2
reissue.
months early or something?
Yeah, they'll reissue the prescription.
Okay.
Yeah, the pharmacy will typically call the doc, say, "Yep, we've already dispensed the full course of therapy. Can you issue another prescription?" And another one will be written. Other questions? I know there's a lot of information, so appreciate y'all sharing questions and happy to address them as they come up. I do want to talk for a moment about MAC lists. These are maximum allowable cost lists. These are essentially price lists that a PBM has negotiated with retail pharmacies. There's a real interesting game that goes on in this world because a PBM doesn't just negotiate a single price with retailers. They negotiate a whole bunch of different deals, if you will. Again, a tale of multiple ledgers, right? And then they in turn decide which MAC list, which deal of their retail deals they're going to give to each client, for example, the state plan or employer down the street, et cetera. And at any point in time, that employer doesn't have visibility into which MAC list they're on or what the prices are on that MAC list. The only way they can determine that is through an audit process. The PBM can move clients from one MAC list to another, and the value, you can see this in a discount off of AWP, the relative value of each of those MAC lists could be wildly different, which means that a PBM could start a plan on MAC list B, and then halfway through the year or halfway through the month, move them to MAC list C where their pricing will be not as good. Now, why would they do that? Well, they've made certain commitments to the plan. We guarantee that we will deliver a discount on generic drugs of at least 80% to the plan. And if they see that they are overperforming that, if their retail pricing is doing better than that, they can in essence use this MAC list game to throttle back on the value that they're delivering to that client at any point in time to make sure that they don't over deliver what they promise. In fact, their goal typically is to underperform slightly and hope that the client doesn't audit. What makes this particularly challenging for plan sponsors is that a lot of PBMs are out there saying that we're giving you a pass-through we're giving you full transparency. We're going to charge you exactly what we pay the retail pharmacies. But unfortunately, because of the manipulation of these MAC lists, a plan sponsor that has that transparent pass-through type of deal with a large traditional PBM often doesn't know what they're getting passed through. That is to say, it could be the best price, it could be the worst price that that PBM has to offer. And so again, this creates additional challenges in the way we talk, even in the way we talk about transparency within the industry. And now I do want to say, this is, I enjoy, speaking with thought leaders about this, but I didn't always have the chance to, because this wasn't even really a public policy issue until somewhat recently. It was certainly, drug pricing and drug costs were a thorn in the side of plan administrators, ERISA plan sponsors, labor unions, but it really only became an issue of public concern recently, due largely to the fact that plans started charging patients more. They moved to high deductibles, they moved to co-insurances, and suddenly patients who were previously insulated from the real cost of drugs, or they were paying $5 and $10 flat copays, are now participants in the economics of this supply chain, right? And so now they are feeling the pain of drug pricing. And so we've seen a real wave of interest among legislators, among the media, and really among patient advocacy groups as well. And you can see that a lot of it started at the state level with a wave, a tsunami, if you will, of state laws that took shape over the last few years. Since 2017, 154 state laws were passed, signed into law. At least one PBM law passed in every US state, laws that directly affect the business practices of PBM. So PBMs are now kind of in the crosshairs of scrutiny. And in 2023 alone, in case you're wondering whether the tide is slowing down or stemming at all, we've had over 130 PBM bills introduced across 43 states. So this is still a very, very hot topic. And in fact, may represent one of the fight against high drug prices may represent one of the few bipartisan topics that a lot of state legislators address. A tsunami of state legislation that addresses a whole wave of different areas of the PBM business model. But you can see that some of these are very relevant to plans and patients, things like no spread pricing or no gag clauses that would prevent retailers from talking about lower price options for a patient, anti-steerage legislation, which is legislation that would prevent PBMs from manipulating, folks into using their owned assets, things like that. So this really is one that I'll call out is NADAC as a reference price, which we're actually going to talk about in a moment, because it's actually been a pretty hot topic here in the state of Mississippi. You could see there were 6 bills introduced recently in your state legislature to address PBM business practices, and 4 of them focused on, at least in part, on NADAC as a more rational way of structuring reimbursement within a retail network. I'm actually very familiar with NADAC in particular because it's the reference price that our PBM uses for our entire commercial book of business. But you can see some of the other elements that are addressed here, things like steerage towards owned assets, spread pricing, equitable reimbursement across pharmacies. Yeah.
House Bill 1135, as you probably know, had nothing to do with that. It dealt solely with just some transparency and trying to get some sunshine on the state contract.
Appreciate the clarification. Yeah, the direction that all of this legislation seems to be going in.
You got it right on your chart.
Yeah, correct. Yeah, did not address NADAC. That's correct. Yeah, but the direction that all of these bills and bills across the United States are going is in a direction of transparency. That is to say, to understand how PBMs make money and how those profit sources may be distorting cost and utilization. Now, I mentioned that we're very familiar with NADAC as an organization. We took a long, hard look at average wholesale price, AWP, which I think we all know the joke. It's, we all refer to it as ain't what's paid, right? It's the list price for a drug, the starting point price. But depending on the drug you're talking about, the actual price out the door could be 99% discount off of AWP or 25% increase to AWP. So the real swings in price are wild. Yes, sir.
If I may, and I hate to interrupt you, but I'm gonna forget my questions.
Yeah.
Before we get to NADAC pricing, let's get back to PBMs. I understand the logic and it makes common sense initially to use PBMs. They have a larger purchasing power and they have the expertise. So it makes sense to me, okay? However, and you look like someone who can handle some tough questions. Before I pose the following questions to you, how does your company is privately owned?
Yeah,
Okay, and you have clients that are governmental entities.
that's correct. Yeah.
Okay, are your contracts public? Can the public see your contracts? Are they transparent completely?
Yeah, particularly for our public entity clients, absolutely. They're subject to FOIA. Yeah.
Okay,
Yeah. The, and if was the question, how do we make money?
yes.
Well, it's very,
Well, and more specifically, does your business model involve rebates?
yeah. So the most important tenet of our business model was that we were going to delink it or totally disconnect it from the price of drugs. That is to say, we do not earn spread. We do not retain $1 of rebates. We do not manipulate the price of drugs. Our revenue, our profit is isolated to an admin fee. So we charge
So
fees.
you get a upfront admin fee, flat rate, negotiated upfront, and that's it.
That's right. And that admin fee may, sorry,
Go ahead.
that admin fee may vary a little by client. There's certain fixed costs that would make our admin fee lower for a very, very large client, a little higher for a small client. But here's a really interesting, this almost shocked me when I first learned and understood our model. We do not charge a different drug price across clients. That is to say, every one of our clients, from the largest client to the smallest client, gets access to the exact same ingredient cost and dispensing fee structure. And it's all based on NADAC, which is National Average Drug Acquisition Cost in the retail setting.
Okay, so having said that, then why doesn't the plan sponsor go to these PBMs and say, hey, whenever they're negotiating the contract, this is the type of contract that we desire, this is what we're willing to pay, delete the rebates, just a flat fee, negotiate a bottom line number and move on.
Yeah. I think clients have tried to do that and they haven't found a lot of success. And it's because the PBM's entire business, the traditional large PBM's entire business, their systems, the way they adjudicate claims, their platforms are all designed for the dual ledger profit model. And so we see large PBMs trying to kind of emulate transparency or mimic it, right? But in reality, there's still spread going on. Case in point, we hear about large PBMs offering employers a NADAC-based arrangement. But what's really going on behind the scenes is they've got an AWP-based deal with their network. They're once again creating that spread and just offering a NADAC-based arrangement to the client. So it's still a tale of two ledgers. And that's what we wanted to get away from as a pharmacy benefit manager. It's one of the reasons we moved to NADAC as a core pricing model. So when I say we offer this, this is exactly what we have contracted with our retail network, and it's what we pass through dollar for dollar to our employer and public plan sponsor clients. And there's a lot of advantages to NADAC, not the least of which is that it follows the real world economics of drugs. Now, generic drug pricing within the large traditional PBM has really is typically tied to AWP, which for generics has actually been relatively flat or actually increased a little bit over time. If there's any pharmacists or folks that buy drugs in the room, you'll know that the real world economics of generics have gone down. Generic prices have decreased year over year by about 5 to 10 percentage points per annum. NADAC is a real reflection of that. You can see the decrease from a same starting point here back in 2015. Year over year, the orange line, which is NADAC for the representative market basket of generics, has gone down. AWP has stayed the same. Now that gap between the AWP where the PBM contracts with their client and the orange, which is real world economics that the PBM gets from their retail network or for their mail order pharmacy, that delta, that differential is an ever widening gap of profitability that the PBM enjoys year over year. So even if you do nothing, in fact, even if a plan goes back and renegotiates their arrangement, gets a slightly better AWP discount year over year, that widening gap overtakes that and allows that PBM to earn even more profit.
So if your profit is based on just a simple admin fee up front, what incentive do you have to use the lowest cost approach pricing pharmaceuticals?
That's great. The incentive we have is enforced by the selection process that clients go through to pick a PBM because it's rigorous and they scrutinize price, they scrutinize unit price. You asked whether our arrangement includes rebates. I don't like rebates, but for better or worse, they are part of the supply chain economics. And so we have just as powerful an incentive to go out, get the best rebates we can for clients. The difference for us is that we pass them all through back to the client. And the incentive there is that if we don't
100%?
100, and it's 100%, not just rebates, but every type of pharma revenue that we get. Because rebates, like I said, are kind of a catchphrase, but there's a lot of money changing hands outside of the formal capital R rebates that are defined in a typical employer contract or typical plan sponsor contract. So AWP ain't what's paid is determined by the pharmaceutical company, and there is no regulation or control. It's a made up number, and pharmaceutical companies can set it wherever they want. Even within a drug, 2 NDCs of the drug can have wildly different AWPs. And this is important because as the PBM goes back and hammers the pharmaceutical company for more rebates, the pharmaceutical company eventually will acquiesce, eventually will give them the rebates, but they'll just build it into the AWP and hike that list price. So yes, rebates are good for a plan, they offset costs, but ultimately the plan is paying for those rebates in the form of an increased list price for the product. NADAC is administered by Center for Medicare and Medicaid Services, CMS. It's administered by way of a survey of hundreds of retail pharmacies that happens on I think a bi-weekly basis. It's a very frequent survey. And it's representative of the pharmacy's acquisition cost. That is how much it costs for the pharmacy to get that drug in-house and put it on their shelves. And then a dispensing fee is layered on top of that within our network. And in terms of sort of which pharmacies would agree to this type of arrangement, the answer is a whole lot. In fact, virtually every pharmacy in the country has signed up for our network, not because it reimburses them more in the aggregate. The interesting thing here is that clients generally see a cost savings when they move to a NADAC-based arrangement like this. But what it does is it stabilizes the profitability of the pharmacy from claim to claim. Because in the current ecosystem under MAC list manipulation, the typical retailer, and if there's any retailers in the room, they'll tell you this, they're losing money on about a third of the claims, 20 to 30% of the claims that go out their door every month. And then they have to figure out how to overcharge patients and plans on the other claims just to make up for it and maintain sustainability. In this arrangement, their reimbursement is isolated to the acquisition cost, and then we layer a fair dispensing fee on top of that. And that covers their operational costs in a more sustainable way while keeping drug costs in total lower. So this is not new. I'm assuming you all have heard this acronym before because it's widely used by the vast majority of state Medicaid programs across the United States, including right here in Mississippi. And as I mentioned, it's administered by CMS. They have a consulting firm that does the algorithm, intakes all the data and processes it. Other questions on NADAC? Now I mentioned that this is now becoming a issue of national importance on the legislative arena, and we do have the U.S. Senate and the House introducing bills that are that intend to address PBM business practices. This is one example of about 8 or 10 that are currently floating around various committee rooms in the nation's capital. This one's called the Pharmacy Benefit Manager Reform Act. It has elements that have achieved bipartisan support, including full pass-through of rebates, no spread pricing. I thought this one was interesting here, that a PBM must tell plan sponsors what steerage elements they have implemented for their plan, which is an acknowledgement that most plan sponsors don't even really fully understand the type of steerage that's going on within their particular benefit design. The reason I bring up national legislation here in the state, we're obviously in a state capital house, but national legislation is important because what we're seeing take shape on the national stage is very similar to the transformation that occurred in the early 2000s in the retirement plan industry, which was, for those of us that have enough gray hair to remember what that industry was like, there was a lot of indirect revenue, a lot of conflict dollars changing hands, a lot of intermediary profiteering going on. and it was starting to affect, pensions and 401k balances. Ultimately, the federal government stepped in and scrutinized this heavily, and with the Pension Protection Act in 2006, basically did away with that and put the onus on fiduciaries to ensure that those middleman fees were disclosed and reasonable. And what we're seeing in the tone of discourse at the national level right now is basically that same dialogue, but obviously applied to the pharmacy benefit industry. The FTC is investigating the 6 largest PBMs, including their group purchasing organizations. So the GPOs are those rebate aggregation entities, which are wholly owned by the PBMs. And again, some of the elements they're looking into are in line with what the legislators are looking into over at the Capitol building. I want to highlight a couple of these business practices, we've kind of moved into the 401 level academics here. So follow me if you will. I think this is really fascinating as a supply chain expert. The federal government is scrutinizing the core PBM business model, and now they're group purchasing their GPO rebate aggregators through the FTC investigation and other laws. Meanwhile, PBMs are responding by moving margin even deeper into the supply chain. These are 2 initiatives, 2 LLCs that have been formed by 2 of the largest PBMs. Quallent Pharmaceuticals was formed by Express Scripts, which is owned by Cigna, and Cordavis is a new LLC that was formed by CVS Caremark. What these entities are essentially drug relabelers. So they look like manufacturers from the outside, and they are filed as manufacturers, but they're not manufacturing anything. They're essentially taking an already manufactured drug from another drug maker and slapping a new label on it. It's a co-labeling arrangement, right? And the reason they do that, well, there's a number of reasons why you would do that, but it's important to acknowledge that what that does is it gives that PBM and the entity that they control here full control over the label of the drug, meaning the NDC, as well as the list price, as well as the rebate that's associated with that drug, if there is one. And what that allows the PBM to do by moving each of those different financial levers is essentially take value, dollars, that used to be called rebates, used to be passed through to a plan, right? And potentially to a patient, and move that margin upstream into this new LLC. Right, so it's actually kind of similar to the maneuver that the large PBMs did with rebates as well. Yeah.
Is that legal if the contract requires 100% of the rebate money to go back to the plan sponsor?
If the PBM does something like this and moves rebate revenue into a bucket that's outside of their core PBM business, then those monies no longer have to be passed through. It's an escape hatch. It's a safe haven, if you will, for value that the PBM would not have to pass through under any of their existing arrangements. Yep. So I point these out as an illustration of how far a typical PBM is willing to go to move revenue and profitability around in the face of scrutiny. And it's really important to understand this cat and mouse game, because as a 20-year veteran of the consulting industry, I've been helping plan sponsors play this game of cat and mouse for 2 decades. And it's really frustrating, right? As someone who is just fighting for clarity and transparency and competitiveness within this industry. And that's really what we believe, that if pricing is transparent and clear, then you will ultimately have real marketplace competition play out. And it's exactly what we've seen in our network as well. Now, I know that I heard in the notes from the prior segment that the state employee plan may be considering a procurement process within the next year or 2. So I did want to spend a few minutes and talk about what I believe are really critical elements to consider as you embark on that journey of procuring PBM services, which candidly can be very overwhelming for many plan sponsors. Let's remember, and you said it best, we hire PBMs because we can't all be experts in the drug supply chain, right? It's really, really complicated. But first and foremost, it's critically important that plan sponsors find advisors that are unbiased, right? Objective, and also understand how to look beyond just the unit cost. And that's been the fundamental challenge with most plan sponsors is that the procurement process and the spreadsheet, the financial spreadsheet that is used to procure PBMs, focuses very heavily on things like rebate guarantees, minimum rebates per claim, and discounts per claim, and dispensing fees per claim. But it often does not pay heed to the way the PBMs behave over time, the way they manage drug mix, what I call the M in PBM, the management part, right? And so we do see, in essence, sort of two types of consultants rising. One that continues to sort of work through the spreadsheets in the old-fashioned way and focus really just on rebates and maximizing those unit prices, and other consultants that are thinking more progressively and understand that drug mix and utilization matters as well. And so it's important to align with those consultants and advisors that are thinking in those terms. Here's other examples of ways that you could incorporate elements of drug mix into a financial evaluation, things like looking at prior authorization, approval and denial rates, looking at auto refill protocols across the different PBMs you're considering. We have a really interesting moment here because we got a lot of legislation that's mandating transparency among PBMs. I recommend that plan sponsors include text from that legislation in their RFPs and say, what would happen if this bill passes? Would you have to change our price? And that's a quick way to tease out which PBMs already have that transparency, that financial alignment, versus those that would have to totally change their business model in order to comply with new legislation. Because, really important, if they change their business model, they're going to change your price as a client. Of course, a little bit self-serving at the bottom there, we encourage clients to consider aligned and transparent PBMs. This is really something that has been a mission of mine from long before I was with Capital RX. As I said, I've seen the supply chain from a lot of different angles, and my goal is to leave it a little better than how I found it. And I believe that financial alignment is at the heart of that mission. So I'll pause there for any additional questions.
I have one. Can the committee have a copy of your contract with the co-ops?
We would have to confirm whether that can be shared with we have to confirm with the client. We're happy to provide you with a template of our agreement though, which is representative of the way we do business with all of our clients.
Please, if you don't mind.
Certainly.
Any questions from the members of the committee?
Certainly. Yep. Yeah, there was one PDF that was distributed, but unfortunately, I think it had a typo in it. So I'd love the opportunity to share an updated version of that if possible, and then we can have that distributed electronically. Well, if there's any further questions, or I'd just like to, again, reiterate my thanks for the opportunity to speak with you all today. As you can tell, this is, oh, yep.
Vice Chairman has one question.
Certainly, yeah.
Thank you, Mr. Chairman. By manipulating the drug pricing at our level here with the state health plan, as well as the rebates that local pharmacists get, just how much does it affect our Mississippi economy, do you think?
Well, rather than guess, which is a dangerous thing to do when you're standing at a podium, I'd be happy to propose an exercise in which we could actually quantify that. And the data is there. The good news is pharmacy benefit data is very precise and very discrete, even better than medical plan data. And so this is often an exercise we do with a lot of different prospective clients, which is to intake their data and show them exactly how our model what type of financial result it would drive for the model. The client can then take that and compare that against their current economics, and it gives them a very clear picture of how it would work.
One more question. We tried to pass, well, there was legislation presented. We got hit really hard by larger companies that are self-insured if we were to go to the NADAC. Just how true is it that companies in Mississippi, their insurance would go up because we went to a NADAC with the state health plan?
Well, again, I can't speak to this state plan specifically, but I can tell you that for the clients that have moved from AWP arrangements to our PBM, which is a NADAC-based arrangement, we see very consistently that their cost structure goes down, that most of them actually see a decrease in cost in year one, and that those cost structures continue into year 2 and 3. We have some analytic studies that we've done on our existing clients that have come from those traditional deals, and I'd be happy to share those with you.
Thank you.
Yeah.
Yes, ma'am.
Going back to your Humira example, what would be from the time you started and went all the way through those different levels of markup, so to speak, what would be the percentage of markup on that one drug before it finally gets to the consumer?
You've struck on the heart of the issue, which is that it is impossible for anyone but the PBM itself to tell you what that margin is in aggregate. What I would encourage you to do is ask your PBM. And if they're not willing to disclose that in detail, I think you have a potential issue of opacity there.
A follow-up statement, if I may. Personally speaking, the chair is not, at this point, more concerned about the rebate money, the pricing. The chair of the House Insurance Committee is trying to get transparency and sunshine on the contracts. The PBMs may be the best thing since apple pie. Your company may be the best thing since apple pie. We have very, very competent and intelligent people working for DFA, and we get the best consultants. I want to make sure they get the best information and the most transparent information whenever they're going into negotiations with whoever it may be. That's the chair's goal. I don't know if I will ever get there, but I'm not going to stop trying. Any other questions? Okay, seeing none, this meeting is hereby adjourned.
Thank you, everyone.
One last speaker, I'm sorry.
All right, I won't take long.
Bob is representing the insurance department and the commissioner. And it's my understanding